Depression and treatment of mood disorders is basically based on the fact that it's all dependent on the biogenic amine theory. That biogenic amine theory typically concentrates on norepinephrine and serotonin. It's usually a deficiency of norepinephrine and serotonin that is associated with particularly depression. Therefore, the whole role is to basically increase these monoamine neurotransmitters, particularly norepinephrine and serotonin. Often, if you reduce norepinephrine or serotonin levels, depression will happen. Reserpine, guanethidine particularly, that will destroy the adrenergic terminal, will induce depression. Basically, the whole neurotransmission issue is to try and increase norepinephrine and serotonin. The way to do this is typically either to reduce their breakdown in the synaptic cleft by inhibiting monoamine oxidase isoform A or by trying to increase the release of norepinephrine and serotonin. Typically, the tricyclic antidepressants were the earliest of all the antidepressant drugs. There are three circle ring, and basically their whole role is to try and prevent the reuptake of the norepinephrine from the synaptic cleft. They have varying blocking activity. They will compete with norepinephrine at the transporter to prevent the uptake, but have no direct effect on norepinephrine synthesis. Basically, the most efficacious of all of the drugs are the SSRIs. The other problem with the tricyclic antidepressants is that they have significant side effects because they're non-specific. They have significant anti-muscarinic activity and anti-adrenergic activity, and therefore the TCAs, you run an extreme risk of the 3 C's, which is coma, cardiotoxicity, and convulsions. They will increase heart rate and may induce tachycardia via vasodilation, and they also have a risk of increased dry mouth and blurred vision. They will block sodium channels and are likely to cause cardiac conduction delays, and will also cause weight gain, significant sexual dysfunction. In the presence of alcohol, they'll increase CNS depression. They will have increased anticholinergic effect if you have more anticholinergic drugs, and basically never combine with monoamine oxidase inhibitors. If you're switching from a TCA to a monoamine oxidase inhibitor, you must have a 14-day washout period. They are metabolized in the liver and renally excreted, often converted to an active metabolite, and have significantly long half-lives, which will increase the risk, particularly of cardiarrhythmias. They can also be used in anxiety disorders, in the treatment of enuresis, neuropathic pain, and also obsessive compulsive disorders. The SNRIs are a little more specific, referred to as the serotonin norepinephrine reuptake inhibitors, and these are venlafaxine, desvenlafaxine, and duloxetine, also used for the treatment of generalized anxiety disorders. They will also cause dizziness and dry mouth, and hypertension may also happen. They have low albumin binding, which means that you have a lot of free drug around. Duloxetine acts as an SNRI, similar adverse effects to venlafaxine, and basically it's metabolized by the cytochrome P450 system. The SNRIs are also effective as an adjunct treating some neuropathic pain. The monoamine oxidase inhibitors, while they're relatively effective as an antidepressant agent, they have significant interactions as far as food interactions are concerned. They will reduce the breakdown of the norepinephrine particularly, and also serotonin, by inhibiting the monoamine oxidase A isoform enzyme. And as a result, you have increased level of catecholamines in the synaptic cleft. The problem with monoamine oxidase inhibitors, they will cause orthostatic hypotension, insomnia, sexual dysfunction, some degree of anticholinergic effects. The biggest problem is the tyramine reaction. While your patients are on monoamine oxidase inhibitors, they cannot take any tyramine containing products, which is all the good stuff and all the fun stuff, cheese, avocado, wine, and so forth, anything that contains tyramine, because monoamine oxidase enzymes also break down tyramine, and increased levels of tyramine will cause the release of norepinephrine, and your patient suddenly will go into hypertensive crisis. SSRIs are the most efficacious of all the of all the antidepressants, and basically they are the fastest acting and have fewer side effects. Fluoxetine is always considered because fluoxetine has basically a relatively important and favorable pharmacokinetic profile. Fluoxetine has a duration of action of 2 to 3 days and is metabolized to an active metabolite called norfluoxetine that has a duration of action 7 to 9 days. So the SSRIs will selectively block the reuptake of serotonin in the synaptic cleft, and the increased levels of serotonin will basically reverse the depression. And they do have a low affinity for cholinergic, adrenergic, and H1 receptors, but this is a very low affinity. They're not associated with weight gain. Fluoxetine may cause akathisia, and particularly in children in the first 2 weeks, there is an increased risk of suicidal behavior. Never abruptly withdraw an SSRI. Your patient will have flu-like symptoms, lightheadedness, uneasiness, sleep disorders, and headaches, often referred to as the flush syndrome. Competition of SSRIs occurs with other drugs to metabolism, so one has to exercise caution, and particularly with lithium, which lead to seizures. They all have long half-lives and have active metabolites that also has long half-lives, which basically provides for a very favorable pharmacokinetic profile. SSRIs may have synergistic sedative effects with other CNS depressants such as alcohol and benzodiazepines. And always remember, the serotonin syndrome can be life-threatening. And the serotonin syndrome is very similar to the neuroleptic malignant syndrome, autonomic nervous system disorders, extended reflexes, relaxation of the jaw and ankles, sustained rapid eye movements, which could be a problem. SSRIs are usually the first-line choice for depression because they have minimal side effects, also for OCD, anxiety disorders, and anemia. Antidepressants are usually reserved for more severe and incapacitating depressive disorders, and SSRIs are more preferred in children and the elderly patients due to an excellent safety profile compared to the other antidepressants. Bipolar disorder basically is a problem in relation to deficiency of catecholamines, or basically excess of catecholamines, and basically lithium is used to treat bipolar disorders because it's considered to be a mood stabilizer. And what lithium does, it prevents the dephosphorylation of inositol monophosphate. As a result, you have reduced levels of phosphatidyl inositol biphosphate, and therefore we are reducing the production of inositol triphosphate and diacylglycerol, which are second messengers and basically cause the excitation. It's well absorbed from the GI tract. 95% is excreted in the urine, and renal absorption does happen in the proximal tubule. Lithium is a problematic drug. Has a very narrow therapeutic window, and typical side effects are nephrogenic diabetes insipidus, malaise, chills, and basically headaches and diarrhea may all happen. Lithium is teratogenic and should not be used basically in pregnancy, and it may also basically cause hyper or hypothyroidism. It's used in acute mania to prevent recurrence of bipolar depression, and also as an adjunct to antidepressant treatment, usually in major